What? Good morning, Dr. Trilok Tejasvi. How are you?
I'm good, Steve. How are you?
Yeah, and I always like to introduce the full name, but I'm gonna stick with your first name, Trilok. It's like more casual, and since we've known each other for so long. Thanks again for joining us on this Beating Melanoma project. And before we get started with this interview, I'm just gonna give you a very brief introduction. So Dr. Trilok Tejasvi is the associate professor at the dermatology department at the University of Michigan, in addition to sort of taking care of patients with a melanoma, which is one of your interest, clinical interest, and you've also have a primary laboratory research interest in looking at translational genetics and epigenetics in psoriasis and other diseases. In addition, that Dr. Tejasvi has been heavily involved with the application of the teledermatology in taking care of patients with melanoma and following them and getting them access. So with that said, I'm delighted to have you to join us on this program. Thanks again for doing this.
It's my pleasure, Dr. Wong.
Call me Steve. Call me Steve.
Okay.
So, before we jump into other stuff, let's get back to some of the basics. What do you do when you see patients? And I've been asking a lot of my colleagues the same question, melanoma experts, and I want to give our viewer a kind of flavor to sort of see how different folks go about what's the interaction with the patient. So when let's say a patient first coming to you with high-risk patient, right? Personal family history melanoma, lots of atypical moles, and they come into your clinic and for an inpatient visit. What's your process? What do you say to them? How do you examine? Let's go through that.
Right, that's a great question. So luckily we have what we call as at the University of Michigan, we have something called as melanoma clinic. So any patients who are diagnosed with a melanoma, they go through that melanoma clinic before they come to what we call a SCAD clinic, which is skin cancer clinic, where we see high-risk melanoma patients, high-risk non-melanoma skin cancer patients. So that's where my interactions with the patients happen, which is in the high-risk skin cancer clinic setting. So the first thing is review their charts, review the history, make sure that what has gone so far, like what stage of melanoma are we dealing with, and everything at the first. So I would do a good review of whatever has been done so far, whatever the patient knows before I get into the clinic. And the beauty of working in University Hospital is all these patients are first seen by our residents, and then the residents come back to us and present those cases to me, and then we take it from there. So that's the privilege. But at the same point of time, you have to, because you are signing on the dotted line, you also need to review their charts before you go in. So based on that, once I have, let's say, for example, if the patient has, as you said, personal history of melanoma, family history of melanoma, and multiple atypical nevi. The first thing is after, going inside the room, I would ask if there are any lesions of concern. I always start with that just because most of the melanomas are either identified by the patient or by the close family, and we come next. So that's the first thing. As soon as we get that thing away, then we start with a complete total skin exam, full body skin exam, which starts from the scalp, looking at every place, the eyelids, inside the mouth, in the ears, nail beds, nails, a complete skin exam, thorough skin exam, including internail cleft, between the toes. And then after I do the first review, then I kind of stand back and take a look at all the moles. If they have multiple moles, I kind of take a look at the moles, especially on the back. And I love dermoscopy, so I follow all of these concerning lesions with whatever clinically concerning lesions which I have with a review with the dermoscopy, and make sure they are dermoscopically non-concerning. So a clinical concern followed by dermoscopy evaluation of all of these lesions. And once I've done with it's not a complete exam without doing a dermoscopy evaluation in my knowledge. So I do that in all my patients. I even sometimes look at pigmented subcares if it's concerning. So that's how important for me dermoscopy is. So once I've done that, then I go and check their lymph nodes. Followed by lymph nodes, I make sure that there's no organ involvement like organomegaly in the form of palpating liver and spleen. And then finally, kind of review of systems, make sure everything's okay. And once this is all done, yeah, of course, we biopsy suspicious lesions and things like that. But then, yeah, this is a comprehensive, kind of review of all body parts, including lymph nodes and organs. That's how I do in my clinic.
Yeah, it's kind of interesting. Like, you and I, we all have the same approach, right? And a lot of folks that I chose to interview, and I sort of feel like, we have the same approach. I mean, and that's why you guys are the melanoma experts, and that you have this approach of sort of, you want to detect the melanoma at the earliest stage, but at the same time, you don't want to perform a lot of unnecessary biopsy, right? And so that combination of whole body exam plus dermoscopy plus photos, and it's a series of sequential action that sort of allow you to pick up melanoma early. I find it's really interesting, and you're the first one that actually said this, which is true, but that most melanomas are first noticed by the patients or the family members and the friends, and they're the one who sort of bring that the attention to their clinician and get this screened, right? So I mean, I think this is a very powerful message that, that's one of the reasons I always tell some of my high-risk patients to get self-exam, basically. And
right. So just to kind of this spiel, which I kind of tell patients is like once I see that they're there, I tell them to look for, if they're over the age of 40, I ask them to look for any new moles which happen, because you should not develop a mole theoretically after age 40, and none of your moles should grow after age 40. And if any of those two changes happen, give us a call. So this is another thing which I kind of follow up in my clinical practice all the time. And it's actually helpful.
Yeah, I mean, I think it's really interesting you put the age qualifier right there, right? Because we know there are a lot of, like in adolescence period of time, that you see the mole actually change and getting bigger, get new lesions. It's once you reach a certain age that you don't really want to see those new nevi popping up, basically. So just how long does that process take? Let's say for a typical, your high-risk patient, let's say someone who have like 40, 50 nevi, one history of melanoma, and by the time they walk into your door and by the time they leave, how long does that take?
So they go through two.
Yeah, you get the two layers because you have a resident.
Right?
Yeah.
So my resident takes a look at it, makes sure that everything's okay. So we kind of go in and say, this is a twofer, like you get two people for one price kind of a situation. So, but looking at it, what I mean to say is, so that it's going to be a thorough exam. So it's somewhere anywhere between 20 minutes to 30 minutes or to 40 minutes based on the number of nevi and the complexity of the patient. Well, let's say, for example, somebody who has MIS and very few moles, maybe it ends within first 20 minutes, whereas somebody who has like 100 moles and they are atypical nevi, then yes, it takes around 30 to 40 minutes.
Yeah, especially consider that you have two people looking at the same individual, like separately, right? So two sets of eyes looking at it. Yeah. And I agree with you. Some of those patients with lots and lots of atypical nevis, it can be challenging, especially when you have to bring up the total body photography for comparison, right? So so let me ask you another question. In your mind, what's the difference between your resident and you, besides you have more gray hair And but I asked this question is because how does a patient? So what are you looking for that allow you to pick up earlier melanoma compared to maybe perhaps some of the inexperienced person like your resident? What are they missing?
So the first thing first, like we are looking at a global picture, and the experience adds to it. Like when you're looking at the lesion, like one of the things is like because I teach and train dermoscopy, that's where I kind of pick up early melanomas, and there are situations where the residents are not able to make the difference, whether it's a melanoma specific structure or things like that. That's where I come in and I help them out, because most of my residents are really good at picking up things. And sometimes we also have this kind of the resident goes and marks some of the lesions, which he wants me to take a look at, like, make sure that he or she is not missing any of the lesions. So we kind of take a closer look. I use dermoscopy skills to kind of differentiate whether it needs to be biopsied or not. So things like that. That's where I think experience, the training comes in handy when you're looking at somebody who has like hundreds of nevi.
Yeah, and I think one of the things I sort of rely on is like this ugly duckling concept, right? You basically sort of, like you said, you sort of step back looking at this entire sector and looking for things that sort of jumps at you that looks different. And then, like you, I use a dermoscopy, like sort of looking at most every single lesions. And I actually, I have this new device now. It's this ChemField 360 device. Instead of using dermoscope, it's this camera, high resolution camera. And I put on the live mode, and they can basically just scan across every single lesion. I'm looking at this on the 30-inch TV monitor. So it's a great experience. And then at the same time, I do some teaching and educate the patient. So that's good. So in your opinion, like, are there any specific melanomas, type of melanoma that's just really difficult, that you find it very challenging?
Right. So I always say pink gives me a problem. Pink lesions, which are amelanotic melanomas. A lot of times they kind of mimic neurofibromas, basal cell carcinomas, or even intradermal nevi. So unless you really are not trained to pick up those things, there is a possibility that you might miss those. And that's one of the things. The other one is seborrheic keratosis like melanomas, which kind of really look like seborrheic keratosis if you didn't use the dermatoscope. Again, I can't emphasize more on dermoscopy because you can kind of pick up these aggressive melanomas, which are kind of hard to diagnose just with the naked eye. So those are the things which I find challenging. The other ones are the melanoma and sun damaged skin, which is kind of also really hard to kind of pick up. So those are kind of the melanomas which I find it hard in my clinical practice.
Yeah, I completely agree. I mean, I think the seborrheic keratosis, I call it the maturity spot, right? And that's just the thing that most patients come in and he says like, oh my God, this is a dark spot. I think it's really worrisome. It fits all the ABCD criteria, but you put the dermoscope on, you can tell right away it's benign. The pink lesion is also difficult because, this is something that most people don't really think melanoma can look like. Pink lesions. That's difficult. But I'm going to shift gears a little bit because this is something I really want to get your insight on, because you're in Michigan and you're a tertiary referral center. You have all those surrounding areas and people have no access, and you sort of build out this teledermatology program out there. And maybe you can give us some experiences in terms of, you sort of did this way before COVID happening, right? And maybe you can tell us do patients take the pictures, send it to you, or the physician send the picture to you, and what that process is like, and also, what are the pitfalls that people should be watching out for when they take those pictures? Because without the good pictures, and you cannot make the right diagnosis, right?
Right. So I have the opportunity I'm lucky to have working in two places, one at the VA, the other one is at the university. So, and I have the privileged working of different kinds of telemedicine opportunities, from what we call a store and forward or asynchronous teledermatology to synchronous, or what we call as video visits. So I'll talk about the video visits in the later half. First, let's get to the asynchronous visits, I think, which is most suited for all dermatologists. So we created this, what we call as e-visits, which are basically at the university, where patients are followed up based on what they have by images taken by the patients. And they are sent through a HIPAA compliant portal. And it comes to the dermatologist or you to kind of review it and kind of prescribe or continue medications or change medications. So that's one way of looking at it. It's a direct-to-patient asynchronous telemedicine application. The second application is like at the VA, where we do a little more comprehensive, where we actually have patients coming to the primary care physicians. And the primary care physicians have what we call as a teleconsult technicians or nurses who are trained to take photographs. And these are nationally trained nurses who are good at taking photographs. These photographs are not just clinical, they also are dermoscopy associated images, which kind of makes it from a kind of a real triage model to kind of management and recommendation model, right? Like you see, you know what it is, and you recommend what needs to be done. Whereas if you saw a pigmented lesion, you now see that it would be hard for you to kind of say, okay, that looks like a pigmented lesion, but I don't know what it is, like whether it's a pigmented seborrheic keratosis or a basal cell or a melanoma. So, and it is a full spectrum from completely benign to a malignant status. So the way we did the other store and forward or the asynchronous technology is like after the veteran comes to the primary care, these images are captured, and these images are kind of sent through, again, a HIPAA compliant portal to us. It all just queues up as in another interface for the dermatologist, and the dermatologist reviews each cases. And the beauty of it, as I said, clinical followed by dermoscopy. It's almost like, that dermoscopy is 2D, whether you see in person or whether you see. So it's a 2D image, so it does not change. So as long as you get a good dermoscopy photo, you will be able to make that diagnosis. And then the beauty of this, again, is like once you diagnose, like let's say you saw a melanoma, we would bring that patient next day or within a week, and that's access, right? Means like that's so important. At the same point of time, if we are for sure know that it's a seborrheic keratosis, we tell them to stay back. So that's the huge difference, which we make that. That's the asynchronous part.
Before we get to the video part, I think, you obviously highlighted the benefit, right? It's about access, it's about triage, it's about relieving patients' concern for benign lesion, and getting the right patient into your clinic faster and sooner, right? And so because you created the system. But I mean, I think the problem is most of the viewers on this platform probably will not have access to you because they don't live in Michigan, right? So the question is, how do they send pictures to their own dermatologist, right? And maybe you can walk us through, because you've seen lots of pictures and lots of bad pictures are taken by the iPhone or Samsung phones. Like, what do you need to see, and what do you ideally want to see images from the patients, like from the lighting, from like different perspectives, so that the purpose of my asking those questions is so that when whoever's watching this, when they're interacting with their own physicians, and they can do a better job, so their own physician can help them in making the diagnosis.
So it's kind of a guidance for the patients, right? Like, how do they take clinically helpful photographs? That's what I call them. I don't say it's the best. We're not publishing textbooks here. We are trying to help them to come up with clinical helpful photographs, which can kind of make us diagnose things. So the first thing is exposure, as you said. So ideally it should be a daylight, a full spectrum bulb can be used. If the outdoor lighting is, outdoor lighting is the best, one should avoid shadows in the photos. If they have a macro option on their phone, use the macro option when they are taking photo of the single lesion. Make sure the photos are not blurry, and take photos kind of perpendicular to the lesions or the rashes, which needs to be evaluated. Kind of minimize the background noise. Like, for example, try to kind of have a neutral background, which the best colors would be like gray, dark blue. Use a solid neutral color. Avoid distractors. Take several views. Choose which is the best and send the best ones to your doctor. Zoom in to show the details, and zoom out to show the location. So these are some important things which you should be.
When you say zoom in, zoom out, I mean, are you basically like you hold, let's say I'm using an iPhone, right? And you don't want people to put on you want people to put on the portrait view model or not a portrait view?
No, it's just the regular mode.
Okay. Just the regular model. So I'm putting on my phone. Just you ask him put on the regular photo mode, not the portrait mode. Just take the regular photo mode. And when you say zoom in, zoom out, are you moving this camera in and out, or you using your fingers to digitally zoom in, zoom out?
You're using your fingers to digitally zoom in and zoom out, because going too close to the image, you might lose the clarity of the image when you're not in focus.
Okay. And then does it help to take like far away pictures so people know like approximately where it is, and then getting really close? And so you want like a far away picture for a clinical overview. So as a clinician, you know where it is, but then you also want a close-up image of the lesion. Ideally, you can zoom in and get into the size. But once you zoom in as a clinician, how do you know the size of this lesion? Do you want them to put some sort of ruler right next to it or anything?
That would be great if they can put a ruler next to it. Yeah, when we do take when we get the photos from our nurses, they do put a ruler next to the lesion. Just kind of gives us a reference, if that is possible. But if we expect all our patients to have a ruler, that's the only issue there. Yeah, I agree with you. So the order in which we would want these photos to be sent is like, the first is the what we call as the forest view or the overall view.
Sure.
And then what we call as the macro view, which is the close-up view. In the overall view, it tells you the anatomical site and tells you which part of the body it is located. Try to involve like take a photo which has a good anatomy. Like, let's say if you are taking a photo of your left arm, just make sure that you have the elbow in place in the picture, so that you know where it is, proximal, distal, and things like that, which helps your dermatologist. And after that, yes, zoom in to kind of take the photographs.
And when you zoom in, let's say if you try to, I mean, obviously you can use this like photo mode, and you can basically look at like how far away you can capture the whole thing. But if you want to take the macro, meaning the close-up picture of that particular lesion of interest, how close should the camera be? Like a 12-inch, 18-inch, 6-inch?
Right. So it should be around 2 inches from the lesion. So within the 2 inches is what you call it as a macro by definition. So you can take within the 2 inches of it and try to see if it helps the focus of it, and you get the macro image at that. And then after macro, we normally, if the patients can afford this kind of dermoscopy attachments which are available out there in the market, they could attach that to the phone and then take a photograph by placing the faceplate of the dermatoscope on the lesion, make sure the dermatoscope is on, and then take the image.
Yeah, those things are really helpful. I mean, I think it become like during COVID, a lot of our patients couldn't come into the clinic, and so they actually went out and bought some of those small dermoscopy attachment, and they're clipped onto the phone, and then took the pictures. And one more thing, when you take the dermoscopy photo, for those out there who's really passionate about doing this, right? And And do you ask him to spray alcohol or something over the side? Do you get the lesion wet, or you don't need to?
So I asked, like this is what I teach my nurses when they take photographs, is like
Sure.
before they take the photograph, especially the dermoscopy photograph.
Are you try to, okay, hold on a second. I'm gonna stop the recording. So when you so for the instructions, like when you're taking the dermoscopy photo, right? And for someone who actually went out and bought a dermoscopy attachment, do they need to spray that lesion with alcohol or something to get it wet, or it doesn't matter?
Actually, it does matter. It's very important to kind of wipe the lesion with alcohol. So when I teach my nurses how to take clinically helpful photographs, that's this important step which I tell them. To like take an alcohol pad, wipe the lesion before you place the faceplate of the dermatoscope before you take the photographs. It actually helps a lot. Means the reason why I do that is because if there are too much scale, which is not visible through the naked eye, the light can kind of reflect back from those scales, and you would not be able to see that dermoscopy image very clearly. So when you take those scales off, it actually helps visualization of deeper structure really well.
Yeah, and I think this is one of the things, the caveat, the subtlety about dermoscopy, because you allow us to see structures underneath the skin that you cannot see with just a naked eye exam. And it has to do with optics. That is, you have to put a little bit of like fluid on top that allows the light to penetrate deeper, penetrate the first layer of skin, get down to the layer of skin when the light bounces back, and that's what we see. So it's not only just like, to me, like I tell my staff, like not only to wipe it up, I actually like have a spray that spray a little bit of alcohol on it. The surface have to be a little bit wet and with fluid on it, and allow you to sort of take a better pictures. So just to summarize, right, for people who are taking pictures, that is, one, you want to stay far away a little bit, and that's the first shot. And because of that, you get a global view, and so you know where it is. And also it gives you an idea about this person because you can see the sun damage, how many moles you have. It gives you some sort of other clues about just that patient's risk level, in a sense. And then you get really up to close, about 2 inches, and then you take a close-up photos. And then sometimes you want to even zoom, digitally zoom, and to take the pictures. But ideally, if there's a ruler right there, so people will know, as you know, the physician can see like how far, how big that lesion really is. And then lastly, if someone went out and bought a dermoscopy attachment, you want to spray it with alcohol and then take the pictures, basically. So those are really great feedback. So now, obviously, do you know if like around the country, a lot of people are doing this, or just in Michigan area, or do you know any other program around the country that's doing this stuff?
Yeah, I think a lot of programs are doing it. Like the VA for sure. Throughout, it's kind of a lot of programs in the at the VA is doing teledermatology, store and forward, and most of it is asynchronous, and they almost all have dermoscopy images associated with it.
So this is in the VA system, that is, they gone to the primary care doctor, and the primary care folks, the nurses take the pictures and then do it, basically. But in regular private, let's say private dermatology office, those places, and you don't see that as much, right? Because it's not a closed system, basically.
Yeah, it's not a closed system. Yes, we at Michigan, we also do a lot of e-visits, but we still have not accommodated dermoscopy images with lesions. But we still do a lot of telemedicine and teledermatology at the university too. But we don't have dermoscopy images associated with that.
So the patient from the general community, so your patient, and they can just send photos in. Now, is it, in your opinion, and how helpful is this like programming in terms, because you don't have dermoscopy, right? And but is it how confident are you with those diagnoses sometimes?
It's tough. Sometimes it's tough. Like, in that situation, we actually bring them back in. Like that's, wish we had dermoscopy, but it's not there.
Yeah, that's one of the most difficult things. I mean, I think you and I are so reliant on this device, and like when the battery runs out, they'd be like, I can't, I gotta go charge my battery. So we're gonna switch next. Maybe you can share with us, like, what is the Michigan program? I know that, you have a lot of talented surgeon, medical oncologist, and radiation oncologist and dermatologist. They're all working in concert. What is, some of the exciting things that you guys are doing for tackling melanomas?
Well, one of the things which we are trying to bring is the total body photography. We still don't have that, so we are working on getting total body skin photography. We are looking at a couple of things. I think that will be a game changer, especially with the new tools which has AI technology built into it, kind of scans for you the changed moles or changed lesions and helps you kind of scan through hundreds of images. I think that's one which we are working on. This is what I know, because this is a part of me which is interested in non-invasive imaging of skin. We did get a couple of confocal microscopes
Yeah.
to kind of add to what we are doing. And then, of course, we all strive to train in dermoscopy as the time goes by, and this is what we have done so far. This is where we are right now.
No, I think like at Sloan Kettering we had this like 360 total body photography. It is great, and it's really helpful for people with lots of moles. And I'm actually bring one to my new institution. And then you're absolutely right. They have those like I think it's just like I think that AI technology is only going to get more advanced, and it's going to really assist us to sort of perhaps serving as a second eye, like the resident you have, right? And well. Trilok, and I know this is sort of time is running out a little bit, and I just want to thank you again for taking the time and talk to us about what do you do in your clinic, and specifically I was really interested in to hear about some of the. Thank you for sharing all the pearls about how to take photos specifically for the patient so that they can tap into these kind of a store forward technology when they're seeing their own dermatologist. Yeah, thanks again.
Perfect. Thank you, Steve.